have with me Ricardo Baptista Leite, who is at the moment a shadow health minister in Portugal and the third time elected member of parliament of the national parliament in Portugal. And Ricardo is a highly accomplished public health specialist and an advocate for health. And he also has many accolades, which include being head of the public health in the Catholic University in Portugal. And he is at the moment deeply engaged with the COVID response. He has been deeply associated with the HIV/AIDS response at the global level as well. He also has founded the Unite platform, which is a parliamentarians platform on global health.
It's a real pleasure to be here and to talk a bit about our experience. Portugal at this point is in 9th place within the European Union in terms of COVID-related deaths, which is a very, very strong indicator, I would say, because there's no deaths are unavoidable in terms of measurement, and so we know that those are real. All the rest is it's much harder to measure. And that being said, given that we have such a fragile health system in terms of its resources, although it is a universal health coverage system, very much actually inspired at the beginning by the English NHS, there was a tremendous concern of how we would react, especially because we have a very very great elderly population in our country. We have 10 million population, 3.5 million people live with someone 65 years or older. And so the implications there are tremendous. If you think about comorbidities and people at risk, I mean, with heart disease is the main cause of death in Portugal, and we know how that's related. We have the highest percentage of incidence of diabetic patients among OECD countries, and we know that uncontrolled diabetes patients also have a higher risk factor. So there was a lot of concern, as you can imagine. And we were fortunate in a way, I would say, to have been hit after Italy and Spain. People were getting conscious very early on of what was coming. It was like seeing a horror movie in advance almost, And so to understand that the people actually, on the week of March 9th, started to stay at home, even before governmental and health authorities told them to, and taking kids out of school. And I remember I delivered a speech here in Portugal where I basically said, cancel everything and stay home if we're going to get through this first wave. And that was when the schools were also closed formally. And that's when the state of emergency was then declared on March 16th, 3 days later. And I think that was critical. It was a very critical moment. Actually, this week was published a study by the School of Public Health here in Portugal that showed that the stay-at-home strategy and the state of emergency led to if we hadn't moved in that direction, we could have had 3 to 4 times more COVID-related deaths. And so that's a very powerful study, which is pretty much aligned if you look at Sweden, which followed a different strategy and has pretty much the same population as us, although different demographics. But in comparison, when you look at death rate, it's about 3 times more than Portugal. And so in that sense, I think that first response, which was an emergency response, so to say, was important. And when, moving forward, then a lot of other measures we can talk about in this conversation had to be taken to make sure that we kept on track in terms of not compromising our efforts until now. Media, I would say, in general, we're very responsible. When I say media, conventional media. Right. And the health authority actually did something interesting, was sign an agreement, an MOU, if you will, with the main media outlets to have like a common agreement of sharing key messages, wash your hands, social distancing, the masks issue. And so that really allowed uniformity, if you will, which is so important in terms of messaging.
Right.
In that sense, I think it went well. In terms of social media, of course, it's a bit more hectic. It's harder to control. However, I think it's a cultural issue that we see less of the kind of controversies that you see in other countries. On one hand, and on the other hand, people were really scared. I mean, what was happening in Spain, now it seems like it was decades ago, but 2 months ago, it was horrible. You know,
Right.
people were seeing their elderly family members go into the hospital and they never see them again. 10 days later, they were dead. And we were hearing these stories of how ICU units were packed, that they didn't have enough ICU beds and ventilators for everyone. They started to have to make very hard choices as physicians.
Yeah.
And so people were very scared. And I think that also the value of, you know, many of the values that are embedded within a very Catholic society, although people are very secular in a way, but I think there's an underlying perception of the value of life, if you will, that I think people, you know, were afraid of losing their loved ones, of especially the elderly, especially what we were seeing in senior homes, for example, as clusters were coming about. And that was, I would say, was the Achilles heel of our response, because we had, there are two Achilles heels in this case. I would say it's healthcare professionals. 11% of our infections occurred among healthcare professionals, which I know is an issue in other countries due to personal protective equipment. Clearly, there was lack of preparedness there. And so I think that was an important issue that could have been avoided. That's a lesson learned for the future. I think things are much better now in terms of what needs to be done by whom and how and when, and with what resources. And the other Achilles heel is clearly the senior homes and appropriate testing, surveillance, and so forth. The health authorities here at the beginning were not very clear on that messaging.
Right.
And that undermined a bit of the confidence around the usage of masks, of the utility in the general public. I was one of the few parliamentarians in our parliament, in the sessions room, using a mask. Because they lowered the number of MPs that could be in the room to 1/5. So, and the health authority was saying, physical distance is more than enough. I said, no. And I'm using the mask. It's not for me. I'm protecting other people, especially because at the beginning of the crisis, I decided to go back into the hospital as a volunteer. And I've been working with the COVID response team in the emergency room in my city. And I knew that I could put other people at risk. And so that was a political statement, if you will. Many people started using masks, but you were right. As the health authority was saying that, this is only for healthcare professionals and so forth, and not being clear on the message, it actually led to the Speaker of the House. We had the celebration of the Carnation Revolution that happened on April 25th. The journalist asked the president, are you going to ask the people at that celebration to use masks? And he said, we shouldn't come to this kind of celebrations masked up, as if it were a negative thing. Following that, there was such outcry, because people started to understand, actually, this is using a mask is actually a sense. There's a sense of responsibility and courtesy to others. I'm protecting those around me, and if others use them, they're protecting me. And that changed the mentality and actually forced the Speaker of the House 2 weeks later to make it mandatory to use masks. And the health authority clearly started to put out the right messaging using the channels that I talked about before in conventional media and also social media to try to get the message through. And it went through very quickly. I think another critical factor was the unlocking of the economy. The government included mandatory mask usage in public transportation and associated fines to that. And mandatory, and my party, we enforced mandatory usage also in closed spaces with other people's, mainly shopping malls and stores, because the only thing the government at the time wanted is for the employees to use it. And we were saying, listen, the employees are protecting the clients, but the clients come in and out, and they're always changing, and you're putting the employees at risk here. Beyond other potential epidemiological links that you can create here. And so now we're at a different point where not using a mask in these situations creates a sense of insecurity, and people look, why aren't you using a mask? You can't enter these stores. I mean, it's by law. People have been respecting that. However, if you're walking alone in the street, nobody's going to ask you. It's not mandatory to use masks. And physical distance was imposed in office spaces so you have to, for example, in open spaces, that's the one place where mandatory mask is not present. But companies had to reduce to one half. Well, based on the size of their office, they had to reduce significantly the number of people physically present. Those are numbers from the health authority. So they use mathematical modeling that we, general public and political parties, we only get access to the final results. Actually, that's one of the things that I've been calling for, is for more clarity and transparency on the data that is being used and on the models that is being used. Nevertheless, this kind of information is extremely important for the management of any crisis. And I would also say the georeferencing of that data is also of critical importance to understand in real time, or as real time as possible, the evolution. And so that's more or less how we've been getting those numbers until now. The real world numbers, if you will, not the estimates, have been calculated by two separate ways. One is registries at the hospitals and clinics, where there are doctors that they have to register each patient to whom we test for SARS-CoV-2. And then there's a separate program which is for labs, be them private or public. Every test they do, they also have to, and then the health authority is crossing over this information, and that feeds into the official numbers. I would say it's critical as we move forward, especially as we get out of this first wave, in preparing ourselves for potential second and third waves. And even if they don't happen, and to prepare us for future pandemics. I mean, this goes to show that there's a lot that still needs to be done in terms of preparedness and response to epidemics. And we can talk about that. But in Portugal, for example, about a month ago, we created a program called Trace COVID, which is basically the program that monitors all suspects, even those that are staying at home. So over 100,000 people that are on this whole surveillance program. They're getting daily calls from health professionals. This is divided throughout the country, and this allows you to understand who's positive immediately and try to detect secondary infections. And having this community-based information as you work, and moving forward to have more biosurveillance studies and models, I would say is fundamental for us to try to predict, to detect in real time, and to isolate when needed. And this is a critical aspect if we want to go back to some kind of normal through which public health can help us provide to the people more than just a stay-home strategy, which kills any economy. And so I think that what we did was needed at that time, but there's no excuses not to do more and use science in our favor to provide better responses moving forward. Portugal now has signed on, along with 4 other European countries, to develop an app that is using low energy Bluetooth technology on cell phones to detect movements without centralizing data. So the data stays on the phone of the person, and it is eliminated 14 days after it is collected. And basically you get a red alert if somebody tests positive within the universe of people, so that you know that you were during a period of time in contact with someone who has tested positive, so you can get tested if you want. It's a voluntary based system.
Right.
And so that's an additional tool, adding to your previous question. As for ICUs, what we are seeing now is the estimates that Portugal have done is that we are still missing, for a potential second wave, 352 ICU beds, which of course is more than the bed. It includes all the equipment, which includes, of course, ventilators. And most importantly, where I would say we have even greater shortage is intensive care specialists, be it medics and nurses. And that's a tremendous challenge, as you know. And so the baseline rationale behind that was that we would look at our needs over the last years in average to our current ICU capacity. And we also calculated the worst case scenario in terms of COVID, which of course has been adjusted to this first wave. And what we've seen is that if the NHS had not stopped an important part of its activities, and there's a lot of collateral damage out of that, as you can imagine, surgeries that were canceled, hospital visits that didn't happen, consultations that didn't happen, diagnostics that didn't happen. So we have a lot of excess mortality, which is not COVID, but is COVID related because it's a collateral damage to COVID.
Right.
But if we had kept the NHS working as normal, we would have overgone our current capacity for sure. And so the idea here is if we build these almost 400 new beds and ensure we have that capacity, we're capable of keeping our NHS working as normal with the new circuits that we have developed in terms of COVID response, because now it's very clear what are the COVID units, what are the non-COVID units. At the beginning, none of this was developed. So the flow of the patients, right? The circuits within the health system. And moving forward, there's also a lot of discussion around should we have COVID hospitals or units or clinics. So basically the idea here is calculating ICU needs should be focusing on current needs beyond COVID, plus COVID. And that it's a very simple calculation. In our case, that's how we did it. And I think it makes sense because, ICU units are, for many complicated surgeries, you need to provide an ICU unit. You have to reserve it for when there's a post-op, patients can go into the ICU unit for 1 or 2 days.
Right.
All of these surgeries, these more complicated surgeries, had to be postponed because we needed to leave capacity for COVID response. And so, as I said, there's one study that was published that showed that excess mortality in Portugal could have been 4,000 people who passed away to non-COVID related issues. So it even surpasses the COVID death toll. I would say that until last week, hydroxychloroquine was part of most regimens. It's been, of course, following the most recent studies, it has been removed by the health authorities due to its lack of efficacy and, in many cases, potential harm. We do have some cases where remdesivir is now being used within clinical studies. I foresee that at least with patients doing oxygen therapy before ICU, that may be an option based on what we're reading out there. Beyond that, of course, anticoagulants have been used in some situations. At the beginning, there was also an association with macrolides and with oseltamivir. But those also have not shown great benefit until now. But there is some variation from hospital to hospital.
And tocilizumab?
No, There hasn't been usage here. Well, I'm saying no, but I've heard that some hospitals have actually put it within their regimens.
Right.
It's not general. If it's happening, it's not a general procedure here in Portugal. So that is true, and although it is a very Catholic country, although many people are secular, the truth is religious holidays continue to be a big thing. So Easter and Christmas, and actually the Prime Minister has already expressed some concern if there is a second wave. How are you going to contain people on Christmas, right? Which is even more a family gathering moment than Easter. But Easter is pretty big. We have this thing where people live in big cities and tend to have their family in smaller cities. And so a lot of traveling normally happens in that time. So what happened was during that period exactly, the government actually used the rule of law through the state of emergency and included for those days, a few days before, a few days after, very explicit restrictions in terms of travel and the type of meetings you could have, of how many people could come together and so forth. So nobody could leave their municipality during that time, and there was actually police control at the entrances and exits. So it was pretty tight. And if there were some people detained but it was a very small number, to be honest. Most people were very respectful. People who thought they could still travel and so forth, as soon as they encountered the police, they were quickly deterred. So I think it was a very important deterrence measure. Supermarkets had a limit in terms of the number of people that could be inside at the same time. So there would be lines with people staying 2 meters apart. Everybody would have to use masks in line and within the shops. Most stores were closed, malls were closed. And so really at that point, as you were saying, it more or less coincided with the peak, right, of new infections. Yeah. So it was getting, a bit scary. People didn't know it could go any way. And I think the very clear messaging from all, opposition and power, government in power, had the same voice. We came together in a spirit of collaboration and unity, saying, now it's up to you. We can make it through, but we need to make sure everybody complies. The president also spoke out in that direction. And media, and I think, news anchors at the end of their reporting would say, please stay home. This is for all of us, and so forth. So there was this unifying message. And at that moment, it was of extreme importance, because without that, I don't know if we would have made it. And so people understood and respected the fact that we couldn't have the traditional Easter. And the idea was, listen, we're sacrificing this Easter so we can have many more Easters to come. Well, we've already touched upon some of them in terms of health system capacity, in terms of need for stronger surveillance systems, and better prediction models and real-time surveillance. I would say that there needs to be a greater sense of urgency, especially when we know that there are more at-risk populations and circuits than others, like thinking about senior homes or mental health institutions and so forth. I mean, people living in these residential areas, we know they're at risk. They have greater risk, and there should be a greater sense of urgency in preparing and training personnel and providing all of the needs they may have. Then I think it becomes very clear, another lesson learned, not only in Portugal, but in a more global aspect, is that health authorities, the way they're built up, are not fit for pandemic preparedness and response. I feel this in Portugal, and I feel this at the European level, and potentially at the global level. And what I mean by this is that, following World War II, it became very clear to the world that we needed to have military reserves that would ensure our security and defense. And, countries are spending nearly 2% of their GDP to ensure that we have these military reserves. And in our region, we actually organized ourselves at a multilateral level through NATO to make sure that we coordinate our actions on these cross-border threats. And that they do what they call war games, which are simulation games, and they have a lessons learned center, and they have action plans of what to do, who does what, when, and how. I think we need exactly the same when it comes to global health emergencies, and that means that we have to have emergency response teams, public health emergency preparedness and response teams on the ground in each country that are just doing simulations of different kinds of potential public health emergencies, be it airborne, droplets, waterborne, understanding these different scenarios, the different kind of risks, and having coordinating bodies at the global level, or at least at the regional level, where we can know what's going to happen when these cross-border threats come in from a biological perspective in this case. And I think that the world cannot, we've had so many potential pandemics over the last two decades. This one hit harder and reached us in the richer world. But may this moment be a calling to all of us to make these profound reforms that many of us in the global health field have been calling for, but really never had the momentum. Now I feel that people understand that there is no economy that can survive, let alone thrive, without security and health. May this moment allow us to bring together the political power, civil society, and the global health officials and institutions so that we can build up this infrastructure that actually is very low cost if we think of the potential impact it may have in terms of preventing living situations with €1 trillion impact in our global economy.
Yes, it's indeed a very strong reminder of the value of public health and preventive and promotive measures.
Well, it would be great if immunity were a reality. We don't know yet. So at least until now, even my city hall is doing population serological testing to the general population. The usefulness of this is very limited, not in terms of IgM and detecting active cases. It's useful for that. But in terms of immunity, we really don't know. And what the studies are showing is that there's a quick rise of antibodies, but there's a quick decrease after patients recover. So how long does those antibodies remain in the body? And what is the title of antibodies that we need to provide a true protection of infection and infecting others? We don't know these responses yet. And so until we have responses, we can't really develop policy based on that. That is not, I remember 2 months ago, some countries were actually talking about having immunological or serological passports. If you have antibodies, you can go back to work. Now we know that's not, at least until now, we don't, and that's not enough. And so I'd love to see more effective testing on that front. And I'd love to see that if we could develop some form of immunity, be it through a vaccine, that would be probably the best solution. But even when we're looking at the results of the vaccine, even the Oxford vaccine, we're seeing that the animal testing phase has shown that it did not avoid infections. It just made the impact of infections less severe on the clinical front, which of course is great. And, would allow us to go back to some form of normal. But we need to be realistic dealing with what, we're trying to accelerate a lot of science here. And I think there are some false promises that have been created in the media and some false expectations that we have to manage very carefully. So this being said, I think we have to use what we have right now until those tools are more accessible. So better testing, vaccine, hopefully more effective treatment. And until then, I think that what we've already discussed here is that the role of surveillance is going to be critical. It's the only tool information is the only vaccine we have right now. And so having that information to act, we could use artificial intelligence even to predict, to prevent, potentially act early. I think these are These are all very important tools that public health can potentially develop. And those are the kind of tools that someone, I'm a bit in both worlds, but on the policy side, that's what you need. You need very practical recommendations. You don't need theoretical conceptualizations about what immunity may mean, right? What you need is what works, what doesn't, and what should I do? And I think that we in the public health field, in the global health field, it becomes more and more clear that we need dealing with policymakers when it comes to crises. We need to be very clear on the recommendations we can give based on the science we have. And that of course, brings out uncertainty. And we shouldn't be afraid to bring in that uncertainty into the recommendations. But it's better to bring in that uncertainty and have an honest conversation than just putting ourselves on the sideline saying, listen, science doesn't give us an answer, so we're not going to help. We don't know if there's going to be a second wave. SARS-CoV-1 basically disappeared in a way, and so and so there is some speculation how strong will this virus be throughout the summer season. And there's some, I think there's a lot of wishful thinking also around that. Hopefully, it'll go away and it won't come back. However, the number of people that have been infected, the number of people that are still active cases around the world in a very globalized world, I think it's very unlikely that we won't have a second wave. The question is, how big will it be? It really depends on our capacity to do what I just said before, to detect early, to predict, to monitor very closely, using biosurveillance, as you were saying, to make sure that we are capable of detecting these cases and being able to proactively make sure that the second wave or the next waves that may come are compatible with our capability to respond. And that also includes in preparing our health systems for the next winter, in the sense that we should lower the impact of other non-related but also impactful diseases. Vaccines for influenza, for pneumonia, and so forth. Having that capability to lower the burden of the health system as much as we can, to release as many resources as we can, will be critical to make sure that we keep our capabilities to respond when the infections happen. If we can avoid them by having very strong public health policies and very clear messaging and making sure that we lower the number of infections, of course, if we combine these different strategies, I think we can potentially be more successful.
Great. Well, Ricardo, it's been a pleasure.
Thank you so much for your time.